campus in South Africa. Over to you, Dr. Moodley.
Hi, Marie. Hello, everybody. So welcome to this second collaborative webinar between the College of Public Health Medicine, which is a constituent college of the Colleges of Medicine of South Africa, and the Faculty of Public Health in the UK. These webinars form part of the activities of our Memorandum of Understanding between the two organizations. For those of you that weren't here for the first webinar, just to mention the MOU between the two countries cover a range of areas, including issues around competency-based education, as well as public health workforce training. So the first webinar focused specifically on issues related to our MOU, as well as on specialist training in the two countries. This one is obviously a bit broader as we focus on public health workforce training in general as the cornerstone of strengthening health systems and making our health systems more resilient. So our presenters today then are not just drawn from the Faculty of Public Health in the UK and the College of Public Health Medicine, but also a number of other organizations that are drawn, that are involved in public health workforce training, and as Maureen mentioned, colleagues from the World Health Organization as well. But obviously, we'll draw on some of the key issues that came up in the first webinar, dealing with competency-based training in South Africa and in the UK, and what lessons there are for the rest of the world. It's also important that we contextualize today's webinar in terms of the COVID-19 pandemic. Obviously, that highlighted a number of inequities, social inequities, and health inequities between countries and within countries, but also highlighted some of the gaps and weaknesses in health systems, and areas that certainly we can look at improving and preparing for the next next public health threat. So the other kind of key issue that we probably will focus on today is the WHO roadmap on the public health and emergency workforce. That's involved both the Faculty of Public Health and our college in terms of collaborating with the WHO on that, as well as a number of other organizations. So let me use this opportunity to thank the colleagues from both of our organizations that have been involved in developing that roadmap. So I think we look forward to some thought-provoking and engaging discussions today. And I think, as I said during the first webinar, I think this is going to be one of many as we look to, as partners, strengthen the public health workforce. Maureen, back to you. Thank you.
Thank you very much for those very articulate insights, Dr. Moodley, and for setting the scene so nicely for our webinar today. So to provide a little bit more information on the webinar and the MOU that we have put together with the Faculty of Public Health in England, I would like to invite Dr. Victor Joseph, a consultant in public health and the current co-chair of the Faculty of Public Health Africa Special Interest Group, to give us a briefing on this Memorandum of Understanding, just so that everybody at the webinar is aware of where the origins are. Over to you.
Thank you, Maureen, and thank you to Dr. Moodley for the overview he's given. As he said, a couple of slides to go through. The main thing really is the lesson we have learned from the previous webinar, which I'll share towards the end. Next slide, please. So briefly, the outline covers 3 or 4 areas. background, I'm not going to touch very much on it. So this is an MOU with roots dating back to 2018, where we had very simple context. One is to share our curriculum, and second one is to examine our examination, to observe our examination processes, and both of those have been achieved. So this current MOU is building on the success of the previous one. So I'm going to talk a little bit more about the content of the current MOU, and then secondly, and I'll touch on the local public health system in one of the English region. And then the final bit there is to talk about the relevant lesson we have learned from our previous webinar. Next slides. So the purpose of the current MOU really is to help serve as a broad outline for cooperation between the two organizations, to commit ourselves to work together and around key activities to advance a common objective. Key thing to note is we want to implement a sustainable collaboration between the organizations. So this is, as Dr. Mudley said, we're looking towards a long-term partnership. Next slide. So just to kind of recap, we had the MOU and we identified 4 priorities. And these priorities, we identified people from both, representatives from both organizations in South Africa and the UK to work to lead on this. One of the priorities is around public health education and training. And in this, we kind of captured 2 objectives. It's about collaborating around shared learning on public health education and competence-based training. I talked about examination processes, how we can be able to share knowledge on that and the assessment process, and also to share about learning on our professionalization of public health and career path, including CPD programs. And then the second area of collaboration is between the registrars groups. Thanks to Maureen and colleagues for making that initial contact, and we have built on that, and that's how actually this current MOU came about. So the vision there is to kind of see how experience can be shared across the 2 systems in terms of supporting training and opportunity, for example, joint placement in both countries. There are challenges there, but I'm sure we can work towards overcoming that, and that's the reason why we have this. Next slides. And the third element of priority area is around helping to understand the public health systems and advocacy. When we were all together, it was quite apparent that one of the tests of public health is to influence systems. And how do we do that? And sharing experience is the key aspect of it. So we, in a way, we started that bit of work in already. There are a lot going in respective countries, either through one-to-one, but we hope that in future webinar, we will be able to kind of organize some specific examples of case studies, what is happening, challenges in different countries, and lesson we can draw from that. The fourth area of collaboration, the priority is around collaboration in the development of public health competence-based training and leadership as well. So in this regard, also we have our training curriculum, how we implement that, support our registrars through the process. But there's something also bigger in terms of how we contribute to WHO action plan, linking with our counterparts in Africa, Africa's Center for Disease Control, and other institutions as well. So those are the 4 areas of our collaboration. It's ongoing. And we are making progress in all those 4 areas. Next slide, please. So we thought it's really helpful to give an example of what does a local public health system look like. I'm giving an example of work that has been in one of the English region, Yorkshire and Humber in England. Just to give you a flavor, before I show that, I just wanted to highlight this triangle. We need to kind of look at the whole system. If we envisage like a triangle, the specialist element, and then you have this kind of senior practitioner, and then you can call at the bottom the wider system. We must not lose sight of this, this big picture. As leaders of the public health system, we must be custodian of not only the middle, but also the lower level. People in different countries might call this different name, but it doesn't really matter. What matters is we need to have the responsibility for building the capacity across those 3 levels of triangles. Next slide. I know this is complex, but if you can bear with me, so 2 or 3 lessons here. There is on the right-hand side, purple, orange side. This is developing public health competent, public health core workforce. You can see there we have the our specialist training program, either through the registrar program, but we do also have a portfolio route. But we have also a range of programs to support people at practitioner level. Some of them actually through degree program, which is coupled with a little bit of work experience as well. And there are some CPD programs. So this is kind of building the specialist workforce. On the other hand, we have people whose jobs are not public health. They are part of health services, but we need to equip them with the basic knowledge how they can be able to embed public health principle into their work around addressing health inequality. And we also have leadership program that we can be able to support both some of the core public health workforce, but also people who are in the National Health Service, but could be in other settings. We also have programs around public health intelligence that are embedded. So those are the key things to kind of pass through that a local public health system fairly complex. Next slide. Again, this is a busy slide, but key message there is we have public health in different organizations, straddling local authority, the National Health Service, and some in other settings. Essentially, kind of outlining the previous slide, the various elements fit into one another. Next slide. So just to touch on what are the relevant lessons that we have learned from the previous webinar, webinar 1. There are about a dozen or so lessons. Number 1 is there is need to ensure that there's regular review of public health curriculum to make sure that they are fit for purpose. And there are needs that issues that come emerge, so we need to take lesson of that. Second one is we need to ensure that there is buy-in from the government. If there is disconnect from the government, we might end up training people who won't be utilized fully. That is also another important part of engagement of the government in terms of funding. The third bullet point there is that we must have the we must take the responsibility for the wider public health system. We must not see ourselves, for example, the top tier specialist or consultant as only for our specialist program. We have the duty to provide training and support leadership to the system below. Also, we are really about addressing health inequality. We must reflect the community that we serve as well, so that people feel that they identify with the workforce that is providing public health service to them. we also need to make sure that we reflect the purpose of public health training. Why are we training public health workforce? That seems to be a simple question, but very fundamental. In different countries, there are different triggers why public health training program started. So in the UK, there was salmonella outbreak in the 60s, and the issue of reviewing the leadership in the system emerged. And I'm sure a similar story in other countries. Out of that review, it was recommended that there needs to be a professional body to oversee public health emergency, for example, health protection issues like outbreak. So each country need to ensure that they are very clear about the purpose why they're training their workforce. Essentials about improving health and reducing health inequality. And then the last bullet point on that one is we need to make sure that the workforce we are training are competent, the output is competent, rounded, and fit to do the job. Next slide. Again, Dr. Moodley did highlight pandemic. It has kind of elevated the role of public health professional as custodian of public health system, both providing technical and managerial support. And I think we need to seize that opportunity and highlight that. Career path is an important consideration, and that is linked to the second bullet point around salaries as well. We need to ensure that there is equity in salary and appropriate level of salary that is attractive. And then the last bullet point there is, I know there's discussion, particularly in other parts of the world, including South Africa, the challenge around multidisciplinary public health system. It is crucial. Historically, public health had attracted people from diverse background, and they contribute significantly. And hence we have public health as part of the definition, the arts and science of improving health and preventing disease. Next slide. So the other lesson is about the public health influence of government policies. Big role for public health in terms of the advocacy. There is also the need to kind of ensure that the workforce planning aspect of it at different level, that could be a district level, local authority level, whatever tiers may be in your respective countries. And we need to think about advocate for the broader public health workforce. There is also the link between public health and the private sector, which is an untapped resource. But also we also need to be more and more cognizant about some of the emerging private sector, particularly commercial determinants of health, things that we need to be aware of and safeguard our public health system. Particularly talk about tobacco industry, drinks industry, and so forth. We need to be strategic and intentional about the space we want our public health workforce to move into and contributing to influencing the wider public health landscape. Next slide. Just to summarize, the MOU has helped us in understanding our public health system in the respective two countries. We'll continue to build on that. I think a lot that we can still learn. We started learning that lesson. The second one is the big message is really need to take responsibility of the developing public health workforce, the wider public health workforce, not just on the specialist specialist cadres. And then the final lesson is there are a lot of relevant lessons that we are already picking. I'm sure from this webinar, we will also kind of learn a bit more in terms of how we can enrich that competency-based public health training and education. Thank you very much. I'll hand over to you, Meron.
You're on mute, Marion.
Thanks, Fatai. All right, now I just wanted to say thank you very much, Victor, for sharing such incredible detail about the MOU and the vision that the faculty share on the purpose of this MOU, and for giving us a sneak peek into the UK public health system. I think the lessons learned from the previous webinar were presented in a very concise way and perfectly articulated everything that had transpired last month. Of note, though, it particularly resonated with me when you said that we are here to reflect our communities and address inequity in health. And I'm sure that resonates with everybody that's here today and anyone with a passion for public health. Public health is multidisciplinary, as Victor had mentioned, and I hope that everyone can now better understand the depth and the breadth of the public health workforce and the role that this cadre of healthcare personnel plays within the overarching health systems. And so to further elaborate on this point, I would now like to invite Ms. Catherine Kane and Ms. Siobhan Fitzpatrick to provide us with some detailed information on the global context and give us some insight into the public health and emergency workforce roadmap that has taken the world by storm. The floor is yours.
Taken the world by storm. You should introduce us everywhere. But in fact, that is what we would like to do. We are in a really unique point right now for the health workforce, and specifically for the public health workforce. In the wake of 3 years when everybody experienced disaster, everybody experienced a public health threat, we are in a very, very unique spot where we have the opportunity to evaluate what we want from our health workforce and what we need from our health workforce, particularly at each national level and particularly tailored to country needs. So at this signal point when, and this is coming from an emergencies background, it's very traditional after an emergency to start saying, well, we need to invest in preparedness and response, and we need to recover. And what the public health and emergency workforce has done is actually made this a very strategic approach to ensuring that the attention that's now placed on recovery, the attention that's now placed on preparedness actually includes what each country needs, which is a strong public health workforce that is delivering on current health needs and is prepared to respond when another emergency happens. So we've got simultaneously people's needs being met, which increases trust. And then building upon that, we have people who are more healthy and more productive, which means that when a disaster happens, they are, and not everybody loves this word, and in fact, it was piloted, it was used extensively in the UK, and my country stole it as a favorite word, but they are more resilient and more prepared against the future. Further, when you're investing in the public health workforce, when you have a health worker in every community, you also have the ability to do surveillance, to pick up threats when they are happening, and rather than when they have happened and have spread. So the public health and emergency workforce, the roadmap and the action plan are derived from bringing together public health institutions, WHO, some emergency response institutions and academic institutions, as well as governments, to come together as partners to plan for the public health and emergency workforce that is needed both globally, nationally, and further subnationally and in every community. So the roadmap is not a WHO pilot, it is a partner roadmap, and that is essentially what is needed for anything on health workforce. We need to ensure that that we are working with stakeholders multisectorally, interdisciplinarily, and between the public sector, academic institutions, and the private sector. Marion, can you move to the next slide, please? So the vision and purpose. I'm not going to insult all of your intelligence by reading, but this is what we're aiming at. This is what the partners have decided in the initial convening and following 2 steering committee meetings to move forward and to devise an action plan that identifies what we would like to do in the first 2 years, and then what we would like to aim for in 5 years of the roadmap. So specifically, what we have done since October, when in our first steering committee meeting, moving towards our second steering committee meeting, which was hosted by the UK, by NHS and Health Education England, was to identify the progress that we've made on 2 objectives. One, by the end of June 2023, all tools and guidance will be available for country contextualization and endorsed by all the participating organizations. And then the second is, by the end of June 2024, at least 100 countries will have benchmarked themselves on the 3 action areas and developed action plans for implementation. Let's move to the next slide. And so what are these 3 action areas? This is a conceptual approach, a strategy for how to approach the public health and emergency workforce that we need. The first action area is to define the functions and services needed. What are the essential public health functions, and what are the sub-functions following 3 years of COVID-19, and we will be updating this to say not post-COVID era, because as we all know, it's still happening. And then we're looking at service delivery and administrative level, setting the individual essential public health functions for subnational and local level. So this is a contextualized roadmap. While we can identify the essential public health functions at a macro level, we are also drilling down into each of these health functions and into the individualized health needs of populations. So action area 2 actually looks at, now that we know what we're aiming at, what we'd like to address, we need to ensure that we have a health workforce that is prepared to address these. And that is through pre-service and continuing education. And my colleague Siobhan will talk about this in much greater depth, but we are looking at what the competencies required by the workforce to deliver on essential public health functions. How should education and lifelong learning materials be designed and delivered so that we have a workforce not only that is competent with the clinical skills, but also has what is frequently referred to as soft skills in order to be able to deliver what the population needs in a trusted manner that in turn strengthens the health system. And the third area is actually mapping and measurement of occupations. What occupations perform these functions, and how do we map and measure them? So for a country, for a planner, you first identify what the population needs, then how you're going to deliver them, and then you have to measure, do I have enough nurses? Do I have enough paramedics? Do I have enough doctors? Do I have enough community health workers to deliver? And then further, if we take some of the WHO approach, we look at a health labor market analysis and we say, what can we afford? What is the labor market? How do we pin? And I was really delighted to hear in Dr. Joseph's remarks, decent work and appropriate salaries mentioned, because these are part of ensuring that our competent workforce is motivated to continue delivering and to continue learning more and ready to respond. So how do we figure out what occupations we have, what ones we need, and then we tailor the academic intake and graduation to ensure that we are creating the workforce that we need. This is also inclusive of a number of occupations that may not even feel themselves part of the public health workforce, but indeed are part of the macro mapping of what is needed. Next slide, please. And so this is, we have had our team look at the essential public health functions needed to respond to the 21st century health challenges. And this is a consolidated list of the top 12. And this was following on a survey and internal consultation, extensive consultation, as well as a review of existing literature and resources to identify the EPHFs. And these EPHFs currently are being drilled down into sub-functions. And I know this will be of interest to many of you, and that the slides will be available following our discussion. So I'll go to the next because I'm taking up too much time. And So I will turn now over to, sorry, I think this is still mine, but I'm going to turn it over to Siobhan, who is going to lead you through the competency framework, as well as composition of the public health workforce.
Sure, thank you very much, Catherine. And so just picking up on this slide, one of the key aspects of the roadmap is very much taking that holistic approach to what we mean by the public health and emergencies workforce. So quite often public health is interpreted as that narrow group of core public health personnel or specialists or in public health. But really, when we look at those essential public health functions, this requires everyone, from clinical practitioners for whom health promotion surveillance is a part of their broader job. It also includes occupations allied to health, veterinary, agriculture, if we think about the One Health principles. So in this roadmap, we are very much taking the approach of that broader, the three groups of the core public health personnel, clinical and allied to health, the broader composition of the workforce. Next slide, please. So if you will forgive me, I have a couple of brief theoretical slides. I'm sure everybody on this call is already well versed with what is competency-based education, but given that there are so many different definitions, terminologies, approaches, I thought it would be helpful just to clarify what we mean by the terms competence, competencies, to give context to the work. So we heard earlier colleagues talking about the goal of competence, the state of proficiency for individuals to be able to perform their work. But of course, within public health, true as everywhere else, it's the unknowns and the contexts. So being able to adapt to those contexts requires the competencies to do so, the flexibility, interpreting evidence, collaborating in teams that are changing all the time. So we think about that learning journey and the contribution of formal education and training towards competence, but also learning on the job. Next slide, please. Within competence, and therefore how we think about the design of competency-based education, we want to think about both what somebody will do, the practice activities encompassing the different tasks, but also the competencies of the person. So as mentioned, things like effective communication, collaboration. So it is those competencies that enable the person to perform the practice activities to the standard required for the context. And of course, when we're designing curricula, we then need to think about that learning journey through the acquisition and application of knowledge, skills, attitudes in the context of practice activities, so that the whole of program approach to the design of learning that really enables learners to develop those competencies towards competence for the practice activities. Okay, theory over. Next slide. So when we are talking about action area 2 within the public health roadmap, there are 4 aims with what we are trying to do here. So there are so many existing curricular competency frameworks, courses out there, but quite often they have a narrow focus of a specific context or a specific occupational group. And we have yet to find one that takes the same breadth of approach of the 12 essential public health functions and the 3 groups of the public health and emergencies workforce. So we're trying to pull together what is already out there through that lens of, but what are the tasks? What are the competencies? And then what are the core knowledge, skills, attitudes as part of that learning journey? And as you can imagine, this is a very broad area of work, including everyone from data analysts, intelligence, clinical responders, vets, supply chain, street cleaners, all occupational groups that have a contribution to public health. So it is a principles-based document. We've aligned it with the 12 essential public health functions, but it is very much a guidance. It's a foundational tool outlining the principles of competency-based education, but also how to then integrate public health into the breadth of those curricula. One of the things that we're very aware of is that quite often people with specific training in public health do not always directly go into public health work, but might end up working in other sectors. But likewise, there are people working in public health who do not necessarily have the public health specific training. So through this work, we are trying to shine a light on the importance of competency-based education oriented to what somebody does, the importance of specific training towards those job tasks, but also the breadth of tasks, the breadth of contributions of the 3 occupational groups. So the framework that we are in the process of developing is very much a guidance, a signposting tool around how to strengthen education. But of course, it's in that broader context of education alone will not solve this. Education has to be aligned with population health needs, with employment, with career pathways, and so on. Next slide, please. So when we are looking at the essential public health functions, you will see that these are very broad. Things like health protection, health promotion, but of course we still need to know protection from the various different threats. And therefore, when we think about what the individual person does towards health protection, this is going to look very different depending on occupational groups, depending on context, depending on countries. So we started by looking at the sub-functions, the services, and then actually breaking those down into, so what are the roles of individual people towards the essential public health functions? Because after all, that is what the education focus is. The EPHFs are focused on what a country or a whole workforce provide. But when we're looking at education, we need to really get into that detail of what do individuals do towards those EPHFs. And you can see it's a bit of a web, and there isn't a one-to-one because everything is interrelated. We cannot have public health intelligence without acting on that intelligence. We cannot have community participation without that being a thread that goes throughout all of the efforts in public health. Next slide. So the way we are approaching this is the EPHFs are the ultimate goal, but then working backwards through curricular design, we then think about, so what are the activities, the practice activities that an individual will do, the competencies that enable them to provide those practice activities, and the foundational knowledge, skills, and attitudes. Last couple of slides. So next one, please. So when we think about our theory of change, we're starting with a competency framework, but of course, this has the goal of providing that shared understanding as to what the practice activities are, what the competencies are, and informing curricula. And of course, it is only through the education and training that we can look to strengthen the health workforce towards the provision of the essential public health functions. For the last slide, I will hand back to Catherine, who will talk about the implementation of the roadmap. Thank you.
So you can see here what we have identified are the action steps and for each action area. And again, you'll be able to access these slides following our discussion, and this is also included within the short action plan that is available on our website, and I will add the link to that. But the goal overall is a strengthened workforce in every country, delivering all the essential public health functions, including emergency preparedness and response, for universal health coverage, for health security, for improved health and well-being. So what overall is our goal? I saw in some chat earlier that we need to address shortages. Dr. Joseph mentioned decent work, which was quite incredible, as well as linkages to synergies with other organizations like the Africa CDC. In the Americas, there's another initiative looking at strengthening the health workforce. So we've observed that the workforce who delivered on emergency needs were the already overtasked health workforce in every country, and those who were rapidly recruited and trained. And that's something that I've observed throughout my career. I remember thinking about this after Ebola. I saw people who were rapidly trained to build trust in communities, to deliver public health information, to do health surveillance, to deliver at community level. And then as soon as the emergency was over, we said, okay, we don't need you anymore. I don't think there's any country that does not need a bigger and a more prepared health workforce. And so what we need to look at is building on evidence and experience in health workforce strengthening to address shortages. We have looked at global shortages, and in 2016, we estimated that there was an 18 million health worker shortage in globally. And we have improved on that. Based on 2020 data, that projected health workforce shortage by 2030 was 15 million. We project that if we continue on the same trajectory, we can reduce that to 10 million, but that is uneven among and between countries. So we want to lean on those proven strategies and those proven approaches to strengthen the health workforce and ensure that we're addressing the deficits that are unfair and inequitable among countries. And this is through a series of 3 elements. Protect the existing workforce. And that is full protection from discrimination, harassment, attacks. This is investing in education, continuous learning, and decent work environments, and doing so together with a wide swathe of partners and stakeholders. And the goal overall of this roadmap is to work with countries to take the action that is needed to meet the health needs of their people, to strengthen the health workforce, to value health workers themselves. And final slide, what is our call to action here? What do we want to get out of having talked to you other than taking more than our time? Sorry, Marion, I'm going to go to the very end. So 1, awareness of the roadmap. What are we trying to do? How can you fit into it? 2, uptake. How can countries agree to take this roadmap, look at their essential health functions, look at their education, and ensure that the design is meeting the needs, and look at mapping and measuring how many health workers they have, what types, and how they all fit into this beautiful puzzle. And then what are the resource needs that need to be identified? What resources need to be available in a country, whether it's domestically or through partnership, in order to make this vision a reality? And then the last one, and this is the last ask for you, is as you are going through this process, especially with the partnership between the UK and South Africa, tell us about your progress and allow us to use your successful approaches and your strategic approaches to tell others how they can map and achieve a strengthened health workforce that is prepared to deliver the essential public health functions, and including emergency preparedness and response. Now we're done.
Thank you so much. Now I get literal goosebumps every time I hear about the roadmap and all that it is doing and the framework that it provides us in order to better understand the complexity that is public health and how it traverses so much of the world, not just of healthcare and service provision. So thank you very much to both Catherine and Siobhan for that incredible oversight. And we will be sharing a link in the chat for anybody who wants to know more about the roadmap, or if any organization wishes to further endorse it. But now to head back to the South African and United Kingdom contexts, next on our list of esteemed speakers is Dr. Harsha Samaru, and she is a public health specialist, a council member of the College of Public Health Medicine, and the current chair of the Curriculum Review Subcommittee for the college. And she has a wealth of knowledge and experience on this topic and is best suited to give us an understanding and overview of the South African public health system with a focus on education and training. So Harsha, thank you very much for joining us today. The floor is yours.
Great. Thanks, Marion, and hi, everyone. I think on behalf of the College of Public Health Medicine, especially our curriculum and assessment subcommittee, it really is a pleasure to share our experiences with you today. Also, it's really a privilege to be part of the UK collaboration with the Faculty of Public Health. I think it's very early days for the Memorandum of Understanding, but as much as the time has been short, I think the engagement and the promise for how we're going to build on this and really impact public health training and public health outcomes is evident. It's certainly from our perspective. I think our countries are quite different in terms of where we are in the journeys of our public health systems. But even with these differences, public health principles and values are universal. And I think we also have a lot to learn in terms of evidence and experiences from each other. I think our public health training was based on the original UK training platform, which has evolved over the years. So we have a lot to learn from the UK system, but in terms of how we've experienced our public health system, I think there are also lessons for others who have changed for what we have to share as well. So I think it really is a promising collaboration, and yeah, I think we look forward to watching it grow in time as well. So today, I think I'm again going to share with you something about our South African historical context and our health system, and then discuss public health medicine training, especially focusing on the curriculum. Currently, we're in the process of a curriculum review, and I think that's important to highlight as well in terms of how we are being responsive to the current public health needs in our context. And I think it's very important for us to focus on the history of our healthcare system and the training that has been linked to it. It's also important for us to focus on the history that we're creating at the moment in terms of the healthcare system and the training systems as well. So after I go through the historical evidence, I'll just tell you a little bit about the current system as well. So starting off in 1919, this is when South Africa had its first national health legislation, the Health Act. This was a union-wide public health act that represented the whole country. There were 4 provincial departments of health that were largely focused on curative services, and local governments that focused on promotive health services. At this point in time, I think many people are aware the services that were provided to people in the country was largely based on race. So it was a very disparate, fragmented system. Yeah. And then moving on to the 1940s and early 50s, there was a lot of progressive thinking within the healthcare sector, especially led by Dr. Gluckman, who was the Minister of Health for a few years during this time. And he was part of the group advocating for community-oriented primary healthcare in the country then. Unfortunately, the leadership changed, and all the promise that was associated with the primary healthcare approach was actually not taken forward with the next administration. And then from 1951 to 1994, I think the impact of apartheid really left its legacy on the health system and fragmented it much more. There were 14 different health administrations. There were 4 main health administrations for South Africa, and the rest based in homelands. In 1952, there was state takeover of missionary hospitals, and this formed the backbone of the Bantustan Health Services, which was health services for non-whites in the country. There's also segregated training. There was a medical school for Black students only in Durban. So there was just one main medical school for training healthcare professionals of other races. In the 1970s, I think the fragmentation of the health services was still evident. We had very curative services that were based at a provincial level and preventative services that were run by the local government. But I think a landmark, especially for us in the public health world, was the establishment of community medicine as a field of study in the country. And this was really in response to the public health needs and for the need for medical officers of health to be based at different levels of the healthcare system, from the local healthcare systems all the way to the national healthcare system. And I think what's important to note is that when the field was established in the country, it was a response to an actual career need, a system need, and a need for a specific type of healthcare personnel. Also important, like other places in the world, this was established as a medical discipline. So it was established under the colleges of medicine of South Africa, and students trained in community medicine were already trained as doctors. Okay, so moving forward a few decades to the 27th of April, 1994, this is when the country had the first democratic elections. We had an interim constitution. We didn't have a health act or a health plan at this time, but there was change in organization of healthcare services. So there was one national Department of Health with 9 provinces, and each province had a respective health department as well. This was all based on the African National Congress Health Plan and based on the principles of primary health care and preventative medicine. The unfortunate thing in 1994 was that the public health service post fell away. So the posts that our discipline was created for fell away as we evolved as a democratic country. So the specialists did not have career pathing within the health system. However, most of the speciality remained, and a lot of people still perform similar roles, but more in a technical capacity as opposed to being part of the actual healthcare system. Another landmark was the final constitution in December 1994, and this provided for different mandates related to healthcare, emergency services, services of vulnerable populations, and environmental health services. But it was in 2003 that the first National Health Act of the Democratic Dispensation was made available. Other landmark legislations that have emerged over time was an amendment to the National Health Act, which included an Office of Health Standards Compliance and the primary healthcare reengineering policy. So this basically strengthened the primary healthcare platform and is the basis of today's healthcare system. And then finally, the National Health Insurance Bill. The country is moving towards universal healthcare coverage and funding. And I think this is something that's quite critical, especially as we are looking at the curriculum for public health medicine specialists. Okay, so just going to give you a brief overview of our national healthcare system without too much detail. We've got a public healthcare sector and a private healthcare sector, and under these, we've got hospital services, district healthcare services, and environmental services. In the private healthcare sector, we've got the for-profit and the non-for-profit sector. The important thing at this point in time is that there's huge disparity in terms of equity. The public healthcare system caters for about 84% of the population, yet is very under-resourced. The private healthcare sector caters for, I think, just under 20% of the population, but a lot of the financing and a lot of the healthcare workers are actually based in the private sector. So this is also an important consideration for the government as they want to move towards a reorganization of the health system to actually base a national health insurance funding mechanism. And then related to the healthcare system, we have the Department of Higher Education and Training. And I think public health medicine falls under the different universities. There are 9 schools of public health in the country. However, I think my colleagues previously have alluded to the scope and the different levels of competencies related to public health care and the wide variability in disciplines that are responsible for providing public health in a country. So today, based on being part of the College of Public Health Medicine, I'm only going to focus on public health medicine training, but of course, the public health workforce is much broader than public health medicine. So in terms of public health medicine training, there's many stakeholders involved. I think previously I mentioned that there's a famous African saying that it takes a village to raise a child, and it also takes many stakeholders to actually train a public health medicine specialist. And I think this is one of the complexities behind training of, well, first professionals and public health professionals in the country. There are different bodies and different disciplines responsible for training different cadres of healthcare workers and different cadres of public healthcare professionals. So to really coordinate this is a mammoth task. That doesn't mean it shouldn't be done, but I think it really does set big objectives for countries and for health professionals training. In terms of public health medicine training, I'll just mention the Health Professionals Council. This is the regulatory body, the different Department of Health establishments that actually fund the training posts around the country. There's also schools of public health medicine at the different universities, and they are responsible for coordinating both the academic as well as the experiential learning for the trainees. And then we have the College of Public Health Medicine, which is responsible for the overall curriculum as well as the final assessment. Okay, so moving on to the actual curriculum. This is just a snapshot of the current curriculum. Training is 4 years. It includes theoretical training as well as academic training. All registrars undergo public health modules as part of the Masters in Public Health programs at the different universities, and they do experiential learning at different points in the healthcare system. And then the knowledge areas, competencies, I think everyone is familiar with. You can look at it later on. And in terms of the assessment, I think the assessment is quite comprehensive. Assessment happens both at the universities as well as via the College of Public Health Medicine. So the registrars complete the modules at the universities and they complete their dissertation at the universities, and they're awarded a Master of Medicine degree. And for the College of Public Health exam, they need to prepare a short report. This is really a report based on work done within the health system. They also have to provide 6 formative assessments that account for the experiential learning. These are six-month periods as a minimum. And then they do the single national exit exam. And here there's written as well as oral examinations involved. So it's quite comprehensive. And at the end of it, public health medicine specialists end up with 2 degrees, a Master of Medicine in Public Health Medicine, as well as a fellowship in Public Health Medicine. And they cannot get either without the requirements for the other being completed. So yeah, I think looking at where we are today, I think as I mentioned earlier, the Council of the College of Public Health Medicine is responsible for defining the overall curriculum for the fellowship. And I think with consideration of the local burden of disease, the health system fragmentation that exists and has changed as well. Also, I think it's very important to acknowledge the blatant health inequities in terms of Gini coefficients. I think South Africa is one of the most unequal countries in the world. And I think we have the opportunity of a lot of health policy reform at this point in time. So based on all of this, it really is a good time for us to be reviewing the curriculum to make sure that we are addressing competencies that are required to meet the health system needs and policy contexts that exist currently. And so to do this, we realize that there are gaps to be addressed. We need to promote responsive public health medicine training. We need to be able to inform training that will produce well-rounded, contextually responsive and performative learners. And I think it was important, I think Catherine and Siobhan mentioned, when we talk about competencies, we're talking about knowledge, skills, as well as attitudes as well. And I think that's really something that's quite important and has been highlighted as we've been going through our curriculum review as well. And then most importantly, we think we do need to promote career pathing for public health medicine specialists. As much as they are employed and they are in different spaces, it's not a formal career pathing that exists at the moment. And there really is opportunity to strengthen the system if established posts at different points in the system do exist. So yeah, in terms of how the process to look at this, there's various levels that need to be considered. There's considerations at the macro level where we're looking at the different requirements based on the country's needs. For example, the Departments of Higher Education, the accreditation authorities, and the College of Public Health Medicine as well. We've also looked at international guidelines for public health medicine practice and relatedly training. That includes the Essential Public Health Functions, the World Federation of Public Health Associations Charter on Public Health, as well as the United Nations Sustainable Development Goals. I think as we're looking at outcomes, these are all really important guiding documents that talk to what the health needs are globally, including locally as well. So these were different documents that we did review. At the meso level, I think here we're looking at what exists at the different universities and schools of public health. This is a bit generic and it's not really, I think,
we are running very much over time. Yes, we are going to have to stop the presentation there. I'm going to give you 15 seconds to summarize, but then we must move on to the next presentation.
Okay, sure. Let me leave this slide then. So yeah, I think in terms of the curriculum review process, these are the different steps that we took to go through. We constituted an expert body of people with experience in the different domains of the existing curriculum. We used a modified Delphi approach. We did extensive consultation, and currently we've got core knowledge and skills areas that have been identified and framed. And then finally, I think in terms of the opportunities and challenges, I think other people have mentioned them. Post the COVID pandemic, there's definitely greater recognition of the field in the country. It's the first time that we've been listed on the critical skills list, which is released by the Department of Home Affairs. And this really shows what the priority skills are in the country. And then, of course, like I said before, we're moving towards a national health insurance environment, which will hopefully, some more public health career pathing for us as well. There are challenges, of course. And I think one of it relates to inequities. There's a variability in terms of coverage and resources across the training centers. And I think this is something we do have to be cognizant of as we plan a national curriculum. There's also existing health system concerns and emerging public health priorities. I think everyone is aware of the impact of climate change. And I think, with all of that, I think others are going to cover this. Apologies for taking a bit too much time. But yeah, thank you once again for the opportunity to engage with you, and I look forward for future engagements as well. Thanks.
Thank you very much, Harsha. Apologies for having to cut you short. It was a very interesting presentation. I'm sure everybody enjoyed listening to it. Unfortunately, we do need to move on with the program, and so we're going to move swiftly along to Dr. David Chappell, who is our next VIP speaker, and he's a public health consultant and academic registrar for the Faculty of Public Health in the UK. David, I'm going to ask you to please stick very closely to time. You have about 7 minutes, but I'm sure you can get across the point in that time. Thank you very much.
Thanks. Thank you. I've got several slides, but I'll move through them quickly because you can read them at a later stage. I'm David Chappell, the academic registrar at the faculty, and I oversee education and training. Next slide, please. I mean, I think that there's a sort of self-evident nature. The public health challenges we all face are broadly similar. It's just the context we're working is different, and the amounts are different. I'm not going to talk about our system. You saw from Victor that there is a rather complex system, even at local level, and when you add in the range of other parts of the system, it is quite complicated. Next slide, please. I'm going to come back to the challenges on the last slide. So next slide, that right. Very briefly, a history. We in the UK, industrialization took place in the early 19th century, and that brought with it huge health problems, and the sort of public health profession started developing out of that. But I think until the 1970s, it was generally people moving into that role without any specific training. And you'll see from the slides, it's the 50th anniversary of the Faculty of Public Health, which is a sort of point of time where people thought that actually people needed to be trained to do these jobs. The other thing I'll pick up from this is that about 25 years ago, we agreed that we shouldn't be privileging the jobs just to doctors. So public health is always multi-professional, but I think the change we've made in the UK is that there isn't a specific unique set of roles for the public health doctors. So you can be what used to be a medical officer of health, but now a director of public health, and come from many different disciplines. And so the training program is open to all professions, and although it was a slightly complicated move with a new register, it seems to be working well. There's still differences, but we're getting close to equity there. And next slide, please. So we kind of traditionally talk about the core public health workforce, the professionals who do public health as their day job. And I'm going to mainly talk about the specialist workforce, which, as I say, is now multi-professional, but the bigger workforce are the practitioners. The biggest group of all, of course, are public health nurses in one form or another. But they also have their own, practitioners have their own registration systems, as do the specialists. And next slide, please. We've talked, a number of contributors have mentioned about the wider public health workforce. We've obviously, you'll note there's some slightly different terminology in play in how we describe this, but many professions contribute to health and well-being in their work, even though they're not primarily employed as public health people. A study a couple of years ago by the Royal Society of Public Health estimated that 15 million people in the UK contribute in some way to public health. That is actually half the workforce. So a bit difficult to kind of have initiatives across the whole lot, but clearly, as was pointed out in the WHO thing, that particularly found in healthcare, but also education, housing, social care have key roles in work that will impact on the public's health. And this is where the public health, the core workforce comes in terms of developing skills in these groups, but also in terms of helping guide their work to prioritize and focus on what they can do and what their capacity to deliver is, because clearly much more can be delivered if you're using the wider workforce. Next slide, please. So we've got specialist registers, and there are such registers for practitioners as well. I can talk another day about the development of the UK Public Health Register, but if we move on to the next slide, please. The routes to the specialist registers are either through the training program, the 5-year training program, which I'll talk a bit about in a minute, or you can, if you've got the skills already. So, for example, if you trained in public health medicine in another country, you can potentially submit a portfolio to demonstrate you've got all the skills that would have happened in a 5-year training program. And we're trying to sort of develop a more flex approaches so that you can do a mixture of a prospective training as well as the retrospective portfolio. Next slide, please. So this is the it takes a village to raise a child. It's a slide designed just to not go through because it shows the complexity of the organisations involved in training. But the Faculty of Public Health is the standard setting body. Next slide, please. So I'll talk a little bit about the training pathway and what a competency-based curriculum is like. So these are screenshots from our curriculum, which you're all very welcome to have a look at. It's a bit of a big and cumbersome document, but this shows that training takes place over 5 years. And I'll come back to the examinations that you take, but essentially during that time, you're going through all the learning outcomes that you need to cover, developing individual competencies. They're assessed locally, so this is important, although it's a national program. The assessment of the competencies is local. Next slide, please. And these are the learning outcomes. You'll see they're very similar to what we saw actually of the key functions. I'll just pick up the last two, which so there is a focus on management and leadership functions, and that final one is integration application is really integrating all those individual competencies. And so I think this is really moving from competence to expertise, and this is assessed at the end of training. And it also is where we assess attitudes as well. So that trying to pull up that more higher level kind of sets of skills beyond just each of the individual learning outcomes or competences. Next slide, please.
1 minute.
Right, okay. So just to show you that each of the competencies has a detailed knowledge base. Next slide, please. That's outlined, and then the learning outcomes. There's examples of where you might get those skills and advice for the supervisor on how they would assess those skills. And that next slide, please. So that's why it is a big document. We have 2 exams. One is more or less a knowledge-based one, taken usually around the 2nd year. It is, by the way, online and open to anyone, not just on the training program, and it gives you diploma status of the faculty. The final membership exam, which we've changed quite significantly in the last few years, is a structured, what's called an objective structured public health examination, which is where you play through a number of different scenarios in front of an examiner, and to show that you're competent at listening and communicating and have the knowledge. Next slide, please. So just to mention, as well as completing the learning outcomes exams, and you have to do a minimum of 48 months in approved training posts to get your certificate. Once you're on the register, you have to keep showing your continued competence. So there's a system of annual professional appraisal, proof of continuing professional development, and a revalidation every 5 years. So unlike a sort of qualification, which once you've got it, you've got it. Unfortunately for our trainees, they've got to keep demonstrating competence. Next slide, please. And there's a system to make sure that certain posts you have to demonstrate that you're on a register, and therefore we know that you're competent to do that post. Next slide, please. So just coming back to the sort of challenges again, as you can see, I've jumped through a rather complicated system, but public health in the UK is one of our challenges is that we're often the poor relation to the healthcare services. I suspect that's quite a common thing across countries. The government is much more interested in accident emergency and waiting times for operations, that kind of thing. So we have to fight to get resources into public health. Also, it's not, we have a bit of a separation between our health services and our local government, which has many of the determinants of health like education and housing and social care in its gift. So so that's one of the sort of particular challenges of our country. We also, because it's centrally funded the training, the government has tended to limit the number of places. So we have a lot of consultant vacancies. So, you know, we have a lot of applications and there's more than 10 applicants for every place on a training program. And yet we're not producing enough consultants to fill the specialist posts. But as been pointed out before, you know, that's just one part of the system of the public health workforce. But we are proud of our training program. We did get an endorsement from the European Schools of Public Health in terms of it being very competency based and multi-professional. So I'll stop there, but I'm more than happy to answer questions. I'll keep an eye on the chat.
Thank you very much for that, David, and for that incredible feat of getting through that in such a limited time frame. I appreciate you sticking to time. Okay, our final speaker before we get to the panel discussion, which I know everybody is keen to delve into, is Abraham Opare, and he is a public health professional, researcher, and project coordinator, as well as a teaching assistant at the School of Public Health at the University of Cape Town. So he is currently pursuing his PhD in public health, and his PhD is looking at the core competencies that are needed by Masters of Public Health graduates in Africa to effectively tackle the population health and health system needs of the continent. Abraham, you have 5 minutes, but the floor is yours.
Thank you. I'm going to try and rush through this as much as I can. So today I'm going to present on a project that is being undertaken by the Association of Schools of Public Health in Africa, which also happens to be my PhD research. And I'm going to basically share the journey so far, especially the methods that we've used in our effort to identify the core competencies, with the hope that any program or organization that seeks to do something similar can more or less learn from this. This will be the outline of my presentation, but I'm not going to go into details for now. The most important thing that I'll share is the methods that we use to identify the competencies, and also because it's different objectives, some of which I've already completed, I'm just going to share some preliminary findings that I have so far. So as I'm sure all of us know, the global public health context is changing, which means that in addition to the increased burden of non-communicable diseases that we have to deal with, there's also the emergence and re-emergence of infectious diseases. A very good example of one we have to deal with is the COVID-19. So what this means is that the public health workforce needs to be equipped with the skills and competencies that they will be able to use to address some of these challenges. And globally, there's also evidence to show that the Master of Public Health program provides some skills to graduates which they can use to tackle some of these challenges. So the main reason, or one of the key things that prompted this project by the Association of Schools of Public Health, is that when you look at MPH programs across Africa, even though the public health challenges are relatively similar, there's a lot of disparities in the training. So it's very possible for you to have a graduate from one program having slightly different set of competencies compared to graduate from another. So there was a discussion as to whether there could be some generic or basic competencies which at least every MPH graduate can have at the end of their training, so that they can contribute to the health system challenge in those countries. So this is a picture of what the project seeks to do. Currently, there's a lot of there's a lack of harmonization, differences in the training. At the end of the day, we hope that there will be some form of harmonization in the training received by graduates. So my PhD, which is linked to this project, is basically looking at using participatory research methods to identify and describe the core competencies that are relevant to addressing these public health challenges in Africa. And also look at, because there might be some challenges in harmonizing these competencies, also identify some of these challenges that could be encountered in the effort to harmonize core competencies across the programs in Africa. The methodology review so far, and probably where we can learn something from, is it's been very participatory. So the whole story started, I think, even before I joined. There was a scoping review that came up with some list of competencies that could be considered for Africa. And then during a plenary discussion at the 2019 ASPA conference, which is the Association of Schools of Public Health Conference in Uganda, these competencies were deliberated upon by the participants that were present, but they mainly look at the broad domains. So they didn't go into the specifics. So from this, about 7 discipline-specific competencies and 5 cross-cutting competencies were identified to be somehow important to the public health context in Africa. Then I took over from there. I reviewed the literature. I also look at public health core competency framework, as well as a curricular document for MPH programs across Africa. So from this, we identify a baseline of what we call a preliminary set of competencies. But because these competencies will be used by graduates, and graduates work with employers, we also interviewed stakeholders from various sectors across health in Africa, which include government sector, NGOs, private sector, asking them what are the competencies, what are the skills, knowledge, and attributes that you think graduates need to be able to address the health challenges in Africa. We also did a survey of MPH graduates, finding out what competencies they took from the program, as well as which of these competencies are most applicable to their current or most recent jobs. And finally, because we want to explore the challenges that institutions might face in adopting the competencies, we also interview heads of MPH programs, and we have plans of interviewing people that have been instrumental in setting up competencies for other programs in other settings. So in terms of finding the literature review, I'm not going to go into the details, but we found out that interestingly, competencies like outbreak management, which are broad competencies, and public health law, which in the context of pandemics and recent happening, we know that are very key to public health practice, are missing from most of these MPH programs. We also found out that most of these programs, they don't touch on the cross-cutting competencies like communication, like leadership. Most of them focus more on the the discipline-specific competencies like biostatistics, epidemiology, among others. In terms of the findings from the interviews with stakeholders, which I think is quite important, most of them said that they expect that once you have an MPH degree, at least you have some leadership competencies. So leadership competencies was one of the things that most stakeholders thought were very important that graduates should have. Also, most of them felt that communication should be an important competency that graduates should be able to pick up from the program. And they gave examples that graduate might have all the knowledge and have all the things that they know, but if they are not able to communicate this effectively to their colleagues as well as the public, then they might not really make the impact that they hope to. Some also mentioned that health promotion as well as advocacy was quite important. And then some mentioned that budget management was key that they think graduates should have. In terms of the survey with MPH graduates, it came up that most of them reported that once they have an MPH degree at the workplace, they expect them to have some competencies like leadership, project management. These are the broad competencies, being able to design a budget, among others. Most of the graduates also felt that their program prepared them for a career in academia as well as research and not more of like the practical work. And then most of them also acknowledged that they didn't really get competencies in the area of outbreak management and public health emergencies. So in conclusion, I would say that using participatory research methods to identify core competencies for any program is very important. And in our case, it has worked quite well, but it also has come up with, it has come with a lot of challenges, some of which is difficulty in finding people that will agree to interview and be interviewed on time, and which means that the project might usually delay and might not go according to the schedule that we have. But in all, it's been something very useful. And we hope that the final result from this project or from this research will not just be applicable to MPH programs, but because some of these competencies are important in other programs, it could be adopted and it could be used to improve those programs. Thank you.
Abraham, thank you so much for that oversight. And I think it was fantastic to see the different contexts and how public health and the challenges seem to be intersecting, regardless of whether you're looking at it from a contextual approach or South African approach or even a UK approach. So now that we have that overview in our minds, and thank you again to our fantastic speakers. And again, sorry for cutting you short due to time, but I would like to invite our very own Fatai Ogunlayi, an acting consultant in public health and the chair of the Registrar Specialty Committee in the UK, to facilitate our engaging panel discussion with phenomenal speakers, and I'll let him introduce the panelists. Fatai, over to you.
Thank you. Thank you very much, Maureen. I'm just checking that you can hear me loud and clear.
Perfectly.
Yeah, fantastic. So thank you. It's a real pleasure to be able to moderate this session. I know we are short on time, but I have confidence in our esteemed panelists because they are highly experienced and they will be able to give us some really succinct answers under the time pressure that we have. But it's a real pleasure of mine because we've got some really incredible people on this panelist. So I will introduce the panelists in a second, but I would encourage everybody who have questions, really burning questions that they would like to raise. There is opportunity to use the Q&A box in the chat function or the Q&A function. Please record those questions in there because we will do our best either to get to them today or to respond to them. And that's a commitment from me to respond to them after this webinar. So it's a real pleasure to introduce to you our panelists. And as I go through the name, please do switch on your camera. The first of which is Professor Neil Squires. Neil is the Director of Global Operation at the UK Health Security Agency, and he is the current chair of the Global Health Committee for the Faculty of Public Health. Welcome, Neil.
Thank you.
And then we have next on the list, Professor Eric Berg, who is a professor in health policy and management, and is also the Chief Executive Officer of the Colleges of Medicines of South Africa. Really a real pleasure to have you with us, Eric. Thank you.
And a public health medicine specialist, we should say.
Public health medicine specialist. Thank you. Thank you very much for that. And then next on the list, we have Dr. Gullen Geddick. Is Gullen with us? I can't see the camera on. But whilst Gullen is switching on, great. So Gullen is a public health physician with over 25 years of experience in human resources for health at national and international level. And Gullen is also currently the coordinator for health workforce development in the WHO regional office of the Eastern Mediterranean. Really lovely to have you with us, Gullen. And then we've got Dr. Raji Tajuddin, Dr. Taj, as is affectionately known as. Dr. Taj is a physician with also over 25 years of experience in child health and public health. He's currently the head of Public Health Institute and Research for Africa CDC, where he oversees Africa CDC's Institute for Workforce Development and oversees the Continental Public Health Research Agenda. Really lovely to see you again, Dr. Taj. And last, and definitely by far not the least in our esteemed panel that we have, we've got Professor Kasia Zabawonska, who is a professor and chair of the Public Health Leadership and Workforce Development, a past president of ASFA, which is the School of Public Health in Europe region, and who has been heavily involved in the development of competency-based education for public health and the professionalization of the public health workforce. Really lovely to see you again, Kasia. Welcome.
Thank you.
I'm hoping you're all as enthused as I am about the experience and the wealth of knowledge we have in our panelists. And I'm really, really looking forward to you guys sharing your insight with us. Just a really quick acknowledgement to Dr. Atiya Mosam, who's done some incredible leadership in the background, but unfortunately wasn't able to join us, and hence why I'm stepping in. And just to acknowledge all our efforts to get us ready for today. So our panelists, I will change the way we're going to ask this question in the interest of time. So you may not get all the questions that that was lined up, but maybe I can start with Neil and perhaps with Eric, Neil and Eric as an opening question, because I think it would be really good to get your reflection as coming from different parts of the world in this regard, your reflection on from your individual context, your individual experience as to what some of the key challenges or some of the key barriers, as well as enablers to implementing competency-based education, not just for the public health specialist, but for the wider public health workforce. So Neil, perhaps if you go first, please.
Oh, thank you very much. Well, I think we're beginning to see how to overcome some of the barriers through the gathering of different groups and organizations that we have on this call. For me, it's important that the curriculum is developed with a view to training people for the agencies that will employ them. So schools of public health need to work with institutes of public health. But then in the background, there needs to be a professional representative of those individuals to ensure that they develop skills, but also have a career path, and somebody protects their interests and promotes their career development and their continuous learning. So this triangle of schools, institutions, employing bodies and professionals is absolutely key. And I think we're seeing that collaboration in this initiative, which is supporting WHO's leadership. But we're also seeing it with the big regional agencies. And again, you've got them on this panel. So Taj and Africa Centers for Disease Control is helping to ensure that there are employment opportunities for well-trained public health professionals across Africa. So I think we've got the beginnings of the solutions here.
Fantastic. Thank you. Yes, please do come in, Eric.
So I'll dive in. And I think what I'm first going to start off and say is that I do not believe that most masters in public health do not develop competence. They develop knowledge, they may develop certain skills, but remember that to assess competence, you need to look at people practicing the discipline in the workplace, and you need to have a set of entrustable professional activities against which you do workplace-based assessment to see they performed it. And in our public health medicine specialist training, we have 4 years in the field. Our Masters in Public Health in South Africa is a theoretical program. So you may be able to develop competence in checking certain statistics capabilities or ability to do a strategic plan, but you can't say that they can do the job in the workplace. So regardless of the whether it's a specialist or any other public health workforce, we need to be cautious about how we use the word competence against entrustable professional activities. And so I think from our perspective, my own view is that the core, the basic competences that you're trying to achieve will probably be common around the world, whether it's in epidemiology, whether it's in management, whether it's in communication and the health promotion. Those are there. The issue is the context in which you're applying it. And for example, in an African context, there are a whole range of things that you've got to deal with, like lack of literacy, traditional beliefs, community health workers, lack of transport systems and other communication systems, and a whole range of skills. But that's not the core competence. It's the application of the discipline into the particular context. And one of our colleagues earlier spoke about context. So when we look at competence, we have to look at it in the context for which people are being trained, and the aim is to work in. And we saw that in South Africa. If we go back a couple of decades, when South Africa introduced antiretroviral treatment in the health system, the people who wrote it had no competence to actually do that, because then they came up with a model that might have worked in the United Kingdom, but it was hopeless for South Africa and failed dismally because they'd failed to take the basic principles of public health in the first place and apply those. And second of all, they'd failed to create the context. And they created a context where someone who needed treatment had to travel 200 kilometers in a taxi from a poor household that didn't have money for food to go and get the antiretroviral treatment. And they didn't realize that they were wondering why they had such a dropout rate. So what I'm saying is that you've got to take competence into context for the application, but the core is the same globally, regardless of the levels of the discipline.
Okay, that's really, really helpful. And I think what I'm hearing, which resonate to some of the points that Siobhan and Catherine was making earlier on about being really clear about what we mean by competency. There's a difference between the knowledge that you acquire from a public health master's to the competencies that you develop from practicing it. So that's really helpful. And Neil, you talked about the importance of linking in the schools of public health with the National Public Health Institute, so ensuring that the jobs is there for the workforce that we're training. So I wonder whether, Dr. Taj, I can bring you in on this point, because Eric talked about the importance of context. And on this score alone, we've got over 30 countries represented. So from an African continental perspective, it would be really good to get your reflection on some of the challenges, but perhaps I can add a second layer to that question and ask, what are the technical support that a regional organization like African CDC can provide to those nations to help them in this journey? Over to you, Dr. Taj.
No, thank you, Chair, for one, invitation to be part of this discussion, and two, let me also acknowledge the various speakers that have actually set the stage for this particular timely and critical discussion. Just 2 weeks ago, there was a global conference in Geneva, the 5th Global Forum on Human Resources for Health. I think we had close to 140 countries represented, which clearly demonstrated the criticality of what we are discussing here today. So I think for Africa, what we are seeing is that there is a clear gap between the classroom and what is needed in the field. And Neil and I are part of the strategic leadership group as far as TEFINET is concerned, to look at the field epidemiology training program, which is really a model that is working, because it's more of 70% field work and 30% classroom. So we really need to find a way to make sure that, or to begin to look at the MPH that is being offered in most of our universities, to begin to move away from just, academic exercise to what is needed in the field. And I completely support and agree with what Eric has alluded to. So that's number one. Number two, on the continent, we also seen a situation whereby the ministries of education that is responsible for training these people, do not have any structured way of engaging the users of the product. That's talking of the ministries of health. And not only that, we also having a situation whereby people are trained but do not get placement because the ministries of finance are not part of the discussion. The ministries of labor and productivity are not part of the discussion. So at the end of the day, you have problem of retention is a problem, job placement is a problem, there is no clear-cut career path, there is no decent salary. So really going forward, I think we need to find a way to bring all these key sectors together in a round table, so that we have a robust discussion and have an agreement on what sort of skill set is required. How do we produce them? How do we ensure that they are appropriately placed in terms of job placement? How do we put in place a career path for them that will allow them to stay back? If not, I think we'll continue to just have issues with this, this workforce, health workforce in particular. And COVID-19 pandemic has clearly, outlined or highlighted the fact that there cannot be health without a fit-for-purpose workforce. So for Africa CDC, we continue to work with our National Public Health Institute to make sure that they have what it takes to first and foremost train and also to absorb those people who have been trained. And then number two, we also continue to work with academic institutions. For instance, the presentation from the Association of Schools of Public Health in Africa. So this is an association that since Africa CDC came on board, we've been working closely with them to see how do we ensure that whatever product that is coming out is actually fit for purpose. Thank you, and over to you, Fatai.
No, thank you very much for that, Taj. I really appreciate it. And the importance that you highlighted of cross-sectorial approach. It can't just be one sector trying to drive this forward. We've got to bring in the education, the finance, and the NPHIs to really make this work. Thank you very much for highlighting that. And before I come to Cassie, I just wonder perhaps I can come to you next, Gullen, because for some of the work that you've done in the Emerald region, and what are some of the specific lessons that you've learned in implementing competency-based education in that region? I think it will be really useful. I've been told that there's quite a number of North Africa and the Middle Mediterranean region present on this call, and I think they'll be keen to hear from you. Over to you. Oh, you're on.
Yes,
yeah.
I realized. Thank you, Fatai. Thank you very much for inviting me to this panel, and good afternoon, good morning, everybody. I think I'll take it to a little bit more practical level because I think quite a number of issues have already been raised. And as mentioned by many other previous speakers, I think COVID-19 has been very much a trigger to pay attention to some of the issues which we knew there was, but we were not maybe paying the relevant attention. So in our region, again, essential public health functions required quite a bit of attention in the last decade. But after COVID-19 pandemic, we realized the countries really had lagged behind in providing these services. And with what we have learned from COVID-19, we have reviewed our essential public health functions in our region. We have a little bit more succinct set of 9 essential public health functions in our region. And on the basis of that, of course, we face the question, who will deliver these functions? And what competencies we need to deliver this? So together with UK Health Security Agency, with Neil and the team, we have worked out what are the workforce competency framework for the region. That's covering the competencies required in the system to deliver the essential public health functions, and it aims to guide health workforce planning as well as identifying training gaps and also guiding the development of curriculum. So, and of course, public health training of public health professionals is one of the important areas that it will affect very much. And also, if we look at, Siobhan already mentioned that, I mean, when we are talking about public health workforce, we are covering a large group of people, but there is a core group, and public health professionals are the core of that group. So, and in our region also, we are really paying attention on that. And what we have seen in the region is that actually 2/3 of the public MPH programs in the region was established in the last decade, since 2009, while only 1/3 was established in the 40 years preceding. So we can see there is an increase, and there is more attention to the competencies, and also in the region, ENFNET is establishing International Academy of Public Health, I think, and they are also working on competency-based curriculum to development of that. So there are some significant efforts and progress in the region. We still have to see the results. And one last point, because Neil started emphasizing that training is one part of the equation, but we need to look at the career paths. And another recent study we have undertaken in the region is looking at we looked at what are the employment opportunities and career paths in the region. And one good thing, we have reached out some alumni of the last 5 years of MPH courses, and we have seen that 80% of them were working in an area related to their training.
Okay.
And 75% was in the region. I think this is quite promising. Thank you.
Fantastic. Thank you. Thank you. It sounds like some amazing work that's going on in there. It would be great if there's a publication somewhere that you can refer people to. It sounds like some incredible work. Thank you. And just reflecting on some of the comments in the chat, Eric and Taj, the point you made about the gap between classroom and workplace is being resonated in there. So there's definitely an agreement on that. And Casa, if I may come to you, given your wealth of experience in this journey of competency-based education, and particularly around professionalization of the public health workforce, it would be really good to get some of your reflection around what are some of the enablers, system enablers that help to make this happen across a region like Europe, for example, that others could learn from.
Thank you very much, Patai, and I would like to greet all the participants who are there behind the screen watching us. And my comments will resonate with what has been already said by our distinguished predecessors in the first part of the meeting. We all acknowledge the importance and urgency of competency-based education for the professionalization of public health workforce. Why? Because they provide closer link with practice, health challenges, and also functions, because they are based on outcomes. On the other hand, the competency-based education also provides a clear definition of the field. So together with the definition of public health workforce, the competency-based education, which is usually based on frameworks, provides a definition of the field, which is multidisciplinary, which encourages cross-sectoral collaboration, etc., because these competencies are based on frameworks. And of course, the second part is a measurement and assessment. It is possible when the competency frameworks or competencies are translated into the tools, which allow for the assessment of the educational achievements from the individual perspective or from the organizational perspective. But there are a lot of barriers, and these barriers have been also mentioned before. And it can be the lack of commitment on the governmental level or on the local level. And then it is related with the financing, for instance, or the organizations are still not ready. And that requires a dialogue and discussion whether the certain aspects or competency-based education or development of the workforce is part of the professionalization roadmap that they want to follow. And one important aspect is that concerning the introduction of the competency-based education, sometimes organizations or institutions or departments realize that there are a lot of instruments or competency frameworks, and they think which one to choose. but they don't know actually which one would fit best. And sometimes the frameworks are just lists of competencies without tools. And here, the importance of the roadmap and the tools that are being developed, that these tools will be translated into specific instruments that will be useful and will guide the discussions. So they need to be operationalized. So I think this is something that can be a barrier if we don't have those instruments yet. But there are also facilitators, and the organizations need to feel that they need to change. So reform. And I think that Harsha was talking about the curriculum reform. So it is a good moment to start and introduce change. So which model framework to take, or perhaps develop a new one, or that has been presented by Abraham. Yes, that something has been done. And we can use the developed framework, but adapt them to the culture, value system, history. And again, we have seen how important it is in specific contexts. So we can't just take the instruments which are ready, but we need to make them their own. So we need to take ownership and do it together with other stakeholders, so that we develop a kind of narrative around professionalization and competency-based education, which is part of it. And we make it part of the mission and strategy so that we talk the same language.
Fantastic. Huge thanks for that. And for me, what I was picking up there is there's going to be a burning desire, a burning platform to which we want to change. And there needs to be a leadership right from the governmental level, department level, to make this change happen. Really, really grateful for that, Cassia, and helpful. And I guess before I hand back to Maureen, there's something to be said around, Dr. Moodley made a point earlier on that if we're thinking about health system strengthening, really at the core of that is the public health workforce. And we've heard Eric made a really good point about the competencies that we refer to. There are commonalities between them, but there are some contextualizations that we need to take on board. And there are some interesting questions around some of those contextualizations. Dr. Puka, I saw your questions in there. What we will do is take those questions back and put them through to our panelists to answer, so that we can respond back to you. But I thought that's been a really good, short, sharp focus. And thank you all to all our panelists for being on point and on time with their responses. And I will hand over back to Maureen. Thank you very much.
Oh, thank you so much, Fatai. Thank you so much to our panelists again. Absolutely amazing discussion. Loving the direction in which this is going. For the sake of time, I'm not going to spend too much time summarizing. I think Fatai did an excellent job about that. But I'm going to ask Dr. Fatuma Abidali, a senior health protection and public health specialist in the UK, to come and give us just some insight into the next steps on what we can take forward from this webinar that has taken place today. Fatuma, the floor is yours.
Thank you so much. And I will also be very, very brief, but thank you so much for the discussions today. Just to wrap up, well, I think we've had a trip today, and we've had a range of really high-level experts and specialists in this field to share their knowledge and to share also the movement that we're making forward to collaborate, to work in partnerships and to develop and to strengthen the public health workforce that we're interested in. There were a couple of things that came up, particularly Catherine and Siobhan's call to action when we're talking about one of the reasons we had this webinar was to be able to raise awareness about the work that's happening with all our different organizations, raise awareness of the roadmap, raise awareness in terms of understanding what workforces we have in place, how we can increase resilience and strength across the workforce. Neil and Victor both mentioned we need more clarity, and a lot of our other colleagues, on career pathways that the public health workforce needs, the professionalization that Cassia just alluded to, as did Neil, the importance as well of thinking around the wider, broader public health workforce, not just the core or very specialist staff that we often think about in relation to public health. Taj and Eric both also spoke about the distinction that we need to have between classroom learning and actual on-the-ground skills needed to be able to get the job done in the field, and how important it is to make that distinction. Again, that comes part and parcel of the competency-based education and the professionalization of public health. We also talked a bit around Abraham's PhD, excellent research that he's doing, and we really look forward to seeing how that work develops in terms of the core competencies and addressing those public health challenges in Africa in terms of the workforce. Taj mentioned the importance as well of having those really wide cross-sector, governmental, high-level, sectoral partnerships to really think and address and invest not just time, but also financial investment in developing a workforce that can deal with current challenges, future challenges across all our regions. Gulin also mentioned the progress that's happening in the Emro region. So finally, I think it's really just to mention that, you know, it's really important, as Fatai just ended, that the workforce that we are talking about does reflect the communities that we're serving. So if anything that COVID taught us is actually how much we rely on our health and our care workers across the system, but also the equity. We know that almost 70% of the health workers across the globe are women, but most of them do not hold leadership positions, and they do not hold positions where they get high salaries. So acknowledging that the workforce we're wanting to train are people who we need to also lift up on their journey as well. I will hand back to Maureen and our closing remarks. Thank you so much.
Thank you so much for that, Fatumo. I think it was a fantastic summary of everything that was discussed here and the core tenets of the learnings that we need to take forward. You know, as we try to reimagine public health as this entity that's responsive and adaptive and suited towards the population health needs. So unfortunately, I can't see Dr. Flavia Sekabouke on the call. Is she here? Oh, yes. Fantastic. Yes. Flavia, the floor is yours. Thank you so much for taking the time to be here with us and provide us with these closing remarks. For those of you who don't know her, even though her reputation precedes her, Professor Flavia Sekabouke is a public health specialist in South Africa and the immediate past president of the Colleges of Medicine in South Africa. And I can't think of anybody better to give the final word on this fantastic presentation and webinar that has taken place. Flavia, the floor is yours.
Thank you very much, Maureen. And I really, firstly, as we did in the last webinar, want to congratulate you and Fatima really for just excellent chairing of these webinars. I think it's as much as we talk about and bring on panels our seasoned professionals, once we see our junior professionals, Maureen and Fatima, really, I think it just speaks to the cliche, as people say, that the future is bright. But really, I think, especially because of today's topic, it is so relevant to showcase the next generation of public health professionals and specialists, and to really showcase the brilliance and excellence. And so I say that really kind of just in my opening in terms of closing this particular webinar, and really to thank all our esteemed guests. We know that people's time is tight, but you've come, all of you across the globe, to be here. And I counted when I got on from about 80 people participating on this particular webinar. And so thank you, colleagues, for giving up your time to come together to discuss this important issue. All our speakers, our esteemed speakers, and everybody who's really made this possible. And as we said, as Dr. Moodley said in his opening, the subject of workforce strengthening and resilience is really essential to our ability, yes, to respond, but also to preempt the health emergencies globally. And so it is important that we create spaces like this one, where we can share our experiences and also our knowledge. And as Marion said as well, we're here really to share globally relevant lessons from the UK, from South Africa, and also beyond in the implementation of competency-based education and training of multidisciplinary public health workforce. We also said we want to engage with all of you in the roadmap to strengthen the public health workforce that's been developed by WHO and partner organizations, but also to discuss the enablers, the barriers, the challenges in implementing competency-based education for the public health workforce. And it is true that I believe that today we really have achieved that. And I think Catherine and Siobhan's presentation of the roadmap is not only a call to action, but it's also a call to interaction with the particular roadmap. And also Cassie, and talking about professionalism, I really believe was just absolutely excellent. Dr. Taj and Professor Eric Buch as well, in terms of really giving us the cold face. And I think we always forget about talking about the on-ground skills, and Dr. Taj even additionally pointing out the areas where we can collaborate as different sectors, I think was very important. And Abraham, I mean, what an excellent presentation of evidence that is very much needed. And so I do hope that we continue on this journey and that we are able to share with all our findings with colleagues from across the globe. And I want to say, do watch this space for further opportunities to discuss and engage. And again, colleagues, this is what happens when we all come together, where we decide to say that where are these spaces which are common to all of us. And so we do look forward to more opportunities to do many things. First of all, to discuss, to learn, to listen, to work together, and to also share the vision for a strong and resilient and prepared health workforce. And also, I do want to say, to foster a long-standing and rich exchange between all our organizations, not only just the colleges of public health medicine of the UK and also of South Africa, but all our organizations. I'm looking at you, Dr. Taj, with Africa CDC, and many colleagues who have been here, so that we really can drive this agenda forward. Thank you so much, colleagues. Back to you, Mary.
Thank you very much, Prof, for that feedback and for summarizing the session and inspiring all of us to continue doing what it is that we are doing. Panelists, speakers, thank you for your time, for your attendance, and for lending your expert voice onto this platform as we try to reimagine public health and try and assert the necessity of our image and of our professions, our various multidisciplinary professions within the public and health space. So before we close, I just want to thank everybody for their time and attendance today, from the panelists to the speakers, but also to the participants who gave off their time to be here, to engage with us. Your questions and your comments in the chat did not go unnoticed. Thank you for being here and being part of this discussion. And we hope that from these webinars, what we can foster, as Professor Sengabuga has said, long-standing collaboration as we understand that global health is something that affects all of us, and making contextually appropriate decisions about our public health response is incredibly necessary to maintain population health and achieve the interrelated goals of universal health coverage and health security for all members of our population in a very equitable way. So thank you, everybody, once again for your attendance and your passion and your dedication to public health. And I hope to see you again in future in similar and various other platforms. In particular, I would like to thank Dr. Victor Joseph for his tireless efforts behind the scenes, for putting this together and providing his unyielding guidance and support at every turn to make this a reality, both the Memorandum of Understanding and this webinar today. I'd like to thank Fatai Ogulai, who was the brains behind this organization and made sure that we were all here together and made sure that this flowed very seamlessly. Fatumo, I can't thank you enough for the support that you have given and the insights that you have garnered. I think your summary today just highlighted how pertinent you are in framing all of this that we have discussed today. And to all the members of the Memorandum of Understanding, Dr. David Chappell, Professor Neil Squires, Dr. Harsha Samaru, Dr. Mary Kabonga, all of you who have made this a reality, thank you so very much. And in her absence, Dr. Atia Mosam, for her tireless efforts in bringing this together. And she was fundamental in setting this all up. So thank you all. It's been a pleasure. It's been an absolute honor to host you today. And I hope to see you all in various spaces in the future. Thank you all.